In this video series, we'll explore the most commonly used antepartum assessments that help monitor fetal well-being throughout pregnancy. These 5 tools, Fetal Kick Counts, Nonstress Test, NST, Biophysical Profile, BPP, Contraction Stress Test, CST, and Maternal Serum Alpha-Fetoprotein, MSAFP, are essential in identifying potential complications before they become emergencies. Whether it's checking fetal movement at home or interpreting test results in the clinic, these assessments guide critical decisions in prenatal care. We'll break down when each is used, how they're performed, and what the results mean, all with a focus on what nurses need to know. Let's get started. The Biophysical Profile, or BPP, is a non-invasive, detailed assessment of fetal health. It combines ultrasound imaging and a non-stress test to evaluate oxygenation and neurologic function. It's especially helpful in high-risk pregnancies to determine if the baby is thriving or needs early delivery. Each of these 5 parameters gets a score of 0 or 2. A baby receives 2 points for a normal result and 0 for an abnormal one, making 10 the highest score. The first 4 indicators are assessed via ultrasound, and the 5th, heart rate reactivity, is evaluated through a non-stress test. A score of 8 to 10 is considered normal. A score of 6 is borderline and may require repeat testing. A score of 4 or below could indicate fetal hypoxia or acidosis, prompting possible intervention or delivery. BPP is commonly performed in the 3rd trimester for high-risk patients, such as those with diabetes, hypertension, or signs of decreased fetal movement, or when a pregnancy has gone beyond 40 weeks. Nurses play a vital role in teaching patients about the BPP, explaining how it works, ensuring proper positioning during ultrasound, and promptly communicating abnormal findings to the provider. Fetal kick counts are a simple way to monitor a baby's health during pregnancy. By tracking how often the baby moves, we can catch signs of distress early. Moms usually begin around 28 weeks, or sooner if the pregnancy is high risk. These counts are easy to do at home, and they can literally be life-saving. The most common method is count to 10. Mom counts baby's movements until she reaches 10. This usually takes less than 2 hours. Movements include kicks, rolls, jabs, or flips. Hiccups may feel rhythmic but don't count toward the total. Some providers prefer the Cardiff method, where moms record how many kicks they feel in 1 hour. Others may suggest hourly trend tracking, especially if there are concerns. If the baby isn't moving much, change position, eat something, and try again. Still fewer than 10 movements? The patient should call their provider immediately. Nurses teach the mom how to do kick counts, give her tools to track it, and emphasize why it matters. A calm explanation helps reduce anxiety and builds trust. Not all moms will feel confident doing kick counts. Some may be too busy, anxious, or unsure if they're doing it right. It's our job to normalize it, break it down, and help them feel empowered. Kick counts are more than a routine task. They can detect early signs of fetal hypoxia and help prevent adverse outcomes when followed properly. Changes in movement often come before changes in heart rate. Early detection saves lives. Maternal Serum Alpha-Fetoprotein, or MSAFP, is a screening test used during the 2nd trimester of pregnancy to assess the risk for certain birth defects, particularly neural tube defects and chromosomal abnormalities. It's simple, non-invasive, and based on a maternal blood draw. The test is used to detect elevated or decreased levels of alpha-fetoprotein, which may suggest conditions like spina bifida, anencephaly, or chromosomal abnormalities like Down syndrome. It doesn't confirm a diagnosis but flags pregnancies that may require further testing. MSAFP is done with a simple maternal blood draw, usually between 15 and 20 weeks gestation. It's often combined with other markers in what's called the quad screen, which includes HCG, estriol, and inhibin A, to improve accuracy in identifying potential problems. Elevated MSAFP levels can indicate a neural tube defect, while low levels may suggest trisomy 21 or 18. However, many factors can affect the results, such as incorrect dating, so abnormal results always require follow-up, often through ultrasound or amniocentesis. It's important to remember that MSAFP is a screening tool only. It cannot diagnose. Abnormal results should always be confirmed by diagnostic tests like amniocentesis. This distinction between screening and diagnosis is frequently tested on exams like the NCLEX. The Nonstress Test, or NST, is a non-invasive way to assess fetal well-being by evaluating how the baby's heart rate responds to movement. It's one of the most common antenatal tests used in the third trimester. NST is often used in high-risk pregnancies, postdates, or when there's concern about placental function or fetal oxygenation. It may be done weekly or even twice weekly depending on clinical need. 2 monitors are placed, one to track fetal heart rate and another for uterine activity. The test usually lasts 20 to 40 minutes, and the patient may press a button when fetal movement is felt to help correlate with heart rate patterns. A reactive NST shows at least 2 accelerations in fetal heart rate of 15 BPM lasting 15 seconds within 20 minutes, indicating healthy autonomic function. A non-reactive result means there were no fetal heart rate accelerations within a 40-minute period. This suggests possible fetal compromise and typically requires follow-up testing like a BPP or contraction stress test. The nurse explains the procedure, helps the patient relax, and may offer a snack or juice to stimulate fetal movement. Nurses are also responsible for accurate documentation and notifying the provider of abnormal results. The Contraction Stress Test, or CST, is a form of antenatal surveillance used to evaluate the fetus's ability to tolerate labor. It helps determine whether the placenta is providing enough oxygen to the baby during uterine contractions, which mimic the stress of labor. The goal of CST is to detect fetal hypoxia that may occur during contractions. If a fetus shows late decelerations in response to contractions, it suggests the baby may not tolerate labor well. This test helps guide decision-making about labor induction or the need for cesarean delivery. The test begins by recording a baseline fetal heart rate. Contractions are then induced either through nipple stimulation or low-dose oxytocin infusion. The fetal heart rate is monitored for 10 to 20 minutes to observe how it reacts to at least 3 contractions in a 10-minute window. A negative CST means there are no late decelerations in response to contractions. This is reassuring. A positive CST means late decelerations occur with 50% or more of contractions, indicating possible fetal compromise. An equivocal result shows intermittent decels and may require follow-up with further testing like a biophysical profile. CST is typically used when a non-stress test is non-reactive or when there's concern for uteroplacental insufficiency, such as in post-term pregnancies, diabetes, hypertension, or IUGR. It gives additional insight into fetal well-being before labor begins. CST is not recommended for patients with conditions like placenta previa, prior uterine surgery, or preterm labor risk, because inducing contractions could pose a danger. It's also not routinely used due to time and risk factors, often replaced by safer options like BPP. Like and subscribe to RNToolkit for more videos like this.